I will introduce her again, Dr. Bisena Bulica. She is a movement disorder specialist with Henry Ford Health System. She sees patients out in Sterling Heights, Troy, and down at the main hospital, the main Henry Ford Hospital. We refer to her quite a bit. Her patients love her, and I want to thank you again for being here this evening. So go ahead.
Thank you, Mary Sue. So I honestly, I have a call with like Pacific time at 8 o'clock, but I'm always a little bit late. So if at the end of the time we don't have time for questions, I can always try to answer them via email or something like that. And then Mary Sue, Henry Ford's had a bunch of changes. So I see patients in the clinic at Lakeside and West Bloomfield only at this point. We have Dr. Zara Farzal, who's seeing patients down in Detroit and West Bloomfield. And I'm only in Detroit right now to round and do like resident clinics. So I have some inpatient duties some weeks out of the year. So just to clarify, Dr. Zara Farzal is down here in Detroit. I'm only Lakeside and West Bloomfield. So things change around here, just like our new logo. So this is Henry Ford's new logo.
The new logo.
I know, had to update it. But at any rate, tonight we're talking about managing non-motor symptoms of Parkinson's disease. And sorry, there we go. So as far as an outline goes, we're going to talk briefly about Parkinson's disease. I know all of you are very, very familiar. And the focus of tonight's talk is to focus on the non-motor symptoms, the non-physical symptoms of Parkinson's disease. And oftentimes these can be just as disabling as the physical symptoms. And when James Parkinson, kind of first described Parkinson's disease back in 1817, the non-motor features were obviously not at the forefront. But as we've learned more about Parkinson's disease, we now know that it's a systemic disease, meaning it affects pretty much the entire body. And so depending on what may be going on with one person, we may focus on one area versus the other, but each person's Parkinson's disease is very, very unique. And all the things that we're going to talk about tonight and hit on, this does not necessarily mean that every single patient is going to have every single thing, but it's a very, very, this disease affects everyone differently. And so we have to at least be aware of most of these issues, so that if they do pop up, that what's Parkinson's and what's not Parkinson's. So it's just a good review. And overall, it's considered a team approach. Again, Parkinson's disease, yes, it's a neurological condition. Yes, it's a neurodegenerative condition, but it's also, again, considered a systemic disease. So for any given person, they might have a whole team of people on their side. And so when your neurologist or your movement disorder specialist maybe refers you to, say, psychiatry or urology or cardiology or any of these other subspecialties, it's not because they don't think it's related to Parkinson's disease, but it's because they want the expert in those areas to help take the best care of you possible. So it ends up being a very, very much a team approach. So clinical features, again, the motor symptoms, we have a short column of tremor, bradykinesia, rigidity, dystonia, and gait impairment. And the non-motor symptoms get actually 2 columns, because there's a lot more non-motor symptoms that we run into compared to the more physical symptoms. And, some of these include blood pressure fluctuations, urinary symptoms, and constipation, which are thought to be autonomic issues. As far as just quickly diagnostic criteria of Parkinson's, you guys, if you've been diagnosed, you know what your personal symptoms are, but most people have tremor. That doesn't always have to be there, but bradykinesia, or a slowness in your movements, is a key feature that helps make the diagnosis. And then there's some other supportive features, big one being that you respond well to dopaminergic therapy. And again, this is for the physical symptoms of Parkinson's. And as far as Parkinson's disease goes, by the time you get to see one of us for a diagnosis, we estimate that most people are missing a good 60% of the dopamine producing cells in the substantia nigra. And then those cells that are left are not, unfortunately, they're not healthy. And so this equates to about an 80% reduction in overall brain dopamine concentration. So most people at the time that they're diagnosed typically are running on about 20% of the dopamine that they're supposed to have. So it's a big deficiency from the get-go. And if your doctors have put you through something called the DAT scan, what this typically looks like is reduced uptake of the dye in the basal ganglia part of the brain. And so in this particular patient, there's reduced uptake bilaterally, but definitely less on the right side of the brain than the left. And what this may look like clinically is someone that has maybe more severe symptoms on the left side of their body. As we know, Parkinson's is a bilateral condition, but typically picks on one side first. And the side typically affected first tends to be the most affected side moving forward. And as far as, again, that DAT scan is only looking at dopamine, but we know that in Parkinson's disease, there's lots of other neurotransmitters that are affected, including norepinephrine and dopamine, serotonin, acetylcholine, GABA, all of these listed. And one that's missing on here is also adenosine. So the brain in Parkinson's disease has lots of other neurotransmitters that are, out of balance, so to speak. And it's not as easy or as simple as dopamine being the end all be all. And we've learned this over the years. If dopamine was the only part of the puzzle, then our dopaminergic medications would be the solution for all the symptoms that we run into. And we know, unfortunately, that is not the case. And then as with Parkinson's disease, most people know that oftentimes people, before they come to the office and are officially diagnosed, there's usually a delay, and people may have had symptoms for a few years before the official diagnosis is made. And if we're lucky, we have this honeymoon period of up to 5 years, sometimes 3 years, it depends, everyone's a little bit different, but what we refer to as this honeymoon period is that patients get put on a little bit of dopaminergic therapy, whether it's a dopamine agonist or carbidopa, levodopa. And overall, they're on a relatively low dose and they feel pretty good. The words on and off don't really mean a whole heck of a lot, and they just feel like they have a smooth day. Even if you miss a dose or two, it's not a huge deal. But after about 5 years, most people are running into what's considered motor complications or motor fluctuations. And so people start to kind of watch the clock and pay close attention to the timing of medications, because they're starting to notice that the timing of medications becomes more important, and that carbidopa, levodopa medication doesn't seem to last as long as it once did, or doesn't seem to always do the job as reliably as it once did. If there's any surgical intervention, and this usually is referring mostly, frankly, to deep brain stimulation, we may get a kind of a second honeymoon period where things kind of level off and stabilize, perhaps, because we know that deep brain stimulation is superior for motor symptoms of Parkinson's than medications alone. We have lots of studies long-term now to show that, whether it's subthalamic nucleus or globus pallidus interna as the target, they're thought to be equally effective in helping improve motor symptoms of Parkinson's disease. So if that surgical intervention occurs, there may be a second honeymoon period, though most patients don't pursue that. And so the motor complications and the motor fluctuations kind of persist and continue. And as the progression occurs, there's even more symptoms, that these non-motor symptoms that are quote unquote levodopa resistant. And so again, for most people with Parkinson's, when they take their medications, the words kicking in and wearing off, words on and off become very, very important. When people come to the office, they're often asked how long it takes for the medication to kick in, how long before it wears off, meaning how much time is there with good symptom control. And then what happens sometimes as a side effect of medications, there can be these dyskinesias, which can be happening as the medication is peaking, so these peak dose dyskinesias, or sometimes when the medication is wearing off, people have off time dystonia, where they have cramping in their feet or turning of their foot. And sometimes they can be very pesky, and these diphasic dyskinesias that can occur kind of intermediately as the medication is starting to kick in or starting to wear off. So even dyskinesias are not a one size fits all kind of picture, but the motor fluctuations we know happen with carbidopa, levodopa, because at the end of the day, we're dealing with a very short acting medication that's in and out of your system after about 60 to 90 minutes. And as you lose more and more dopamine, then what you run into is that you're heavily relying on that medication to because you're having less of your own dopamine being produced, you're pretty much relying solely on medication to replace it. And this medication, unfortunately, is short acting. And again, over time, this is just another schematic, but over time, the effects of levodopa become shorter and shorter with some motor fluctuations, so that the window, that therapeutic window of having good on time without any side effects, becomes smaller and smaller. And the medications for Parkinson's disease, when we have any oral medication, whether it's Sinemet or a dopamine agonist or really anything, we're asking that little pill to do a lot. We're asking it has a long journey from the mouth, it's the stomach, the small intestine, where it's getting absorbed all the way to the brain. And so it can be a challenge to have oral medications do the trick for something like Parkinson's disease, especially when the gut, which is very important in getting the medication where it needs to go, is also affected by the disease itself. And there's just some work being done on looking at things like probiotics and just GI flora in general to try to figure out, what we can do better to make it so that the oral medications we currently have available can be better absorbed in the gut. So they're maybe made more reliable than what they sometimes are, because some people will tell you that they take their medication and one dose may work like a charm and the next dose does absolutely nothing. And so there's a lot of this there's a lot more of the medication not being as reliable as the disease progresses. So a lot of work is being done just looking at the GI flora itself. As far as the motor features, you can see it kind of circled here that there's progression over, say, from the zeros, the time of diagnosis, of official diagnosis, but the symptoms kind of progress over the years and decades slowly, but they do progress. But if you look down at the bottom, the non-motor symptoms are thought to predate the existing diagnosis or the physical diagnosis of Parkinson's by sometimes, 2 decades. You can see constipation, REM sleep behavior disorder, loss of sense of smell, depression, things like that. And so these symptoms are usually kind of lurking in the background before the official diagnosis is made and are thought to predate any physical symptoms of Parkinson's disease. So they're very, very important. And as far as the non-motor symptoms go, which is what we're here to discuss, so I'll try to stay on track, but the impact of motor symptoms is huge. So again, like we saw at the last slide, they're present throughout the course of Parkinson's disease, even preclinically before the diagnosis is made. Oftentimes they're non-levodopa responsive, so we don't have a magic pill for some of these things. And this quality of life is very affected by these symptoms. So substantial patients report substantial decline in quality of life from things like fatigue or anxiety or sleep issues or drooling or maybe concentration or memory issues. So these things they're not subtle symptoms, and they can be very, very distressing to our patients. And leg pain, that's an interesting one, because some people would argue, well, leg pain, that might be more of a motor symptom and maybe that patient just needs more medication or something along those lines. So that's one that people will debate. But people with Parkinson's can have nerve symptoms, like neuropathic, kind of like nerve pain, or just aches and pains from Parkinson's disease that maybe don't respond well to levodopa. But that one is a controversial one as far as leg pain goes. Some people consider that more of a motor feature. As far as the neuropsychiatric manifestations of Parkinson's disease, there are plenty. Again, this is a list of the things we're going to talk about or hit on, but this is not a list to say that every person with Parkinson's disease is going to have all of these, or sometimes any of these, especially depending on what stage of their disease they're
Parkinson's thing.
Oh, do you want me to go in the bedroom?
So this slide, I like to always kind of start with this, because sometimes when people see us, they say, well, it just feels like you're just picking a medication and just, kind of, I feel like a guinea pig, we're just trying different things. And the reality is, in some ways, that is kind of what we do. We don't have FDA approval for much in the way of the neuropsychiatric symptoms. So as you can see, for dementia, so for Parkinson's disease dementia, rivastigmine, or Exelon, does have an FDA approval as of 2006. This medication is similar to something called donepezil or Aricept, although rivastigmine comes in a patch and a pill form that's twice a day. And then for psychosis, I'm sure all of you by now have seen the commercials for Nuplazid, but pimavanserin in 2016 gained FDA approval for Parkinson's disease psychosis. But if you look at the most common things we run into, things like memory issues, mild memory issues like mild cognitive impairment, depression, anxiety, apathy is a big one. We don't really have medications for those, so we do our best with the data that's out there. And we sometimes do kind of have to try different things until we get something that works well, because there's not great guidelines for some of these things. So as far as anxiety goes, the data on this is all over the place, but it's estimated that about 1/3 of patients with Parkinson's disease will report having anxiety. And we have to be careful with this one because sometimes it's not necessarily a true like generalized anxiety disorder, but more so a non-motor manifestation of off time. So sometimes when people report anxiety, they'll tell you, if you ask enough questions, that, oh yeah, it happens, before my dose has kicked in, or maybe my last dose of medication wore off early. And people will describe having significant anxiety or feelings of like impending doom, panic attack like feelings every time their medication is starting to wear off and before that next dose, which can take sometimes up to an hour to kick in, has fully kicked in, people will report these symptoms. And so in these cases, we have to do a better job of managing the off time so that we avoid this. And sometimes it's not related to the dopamine medications at all, and it's just that someone has generalized anxiety, or has anxiety along with their depression, or maybe anxiety along with their obsessive compulsive disorder. So this can be kind of multifactorial, but a big thing to not miss is making sure that the anxiety isn't occurring because that we're low on dopamine. And so the biggest strategy is to make sure that we optimize the dopaminergic therapy if that's the issue, the underlying root cause of the anxiety. But if not, then medications like SSRIs or something like Buspar is used. Our psychiatrists are big fans of buspirone as something for anxiety that's not sedating and people can take during the day, especially to avoid some of the benzodiazepines in our patients. And there's also non-pharmaceutical. So during COVID, for example, a lot of people were looking at ways to reduce stress, and mindfulness as a technique has kind of become very popular. In Parkinson's disease, as you know, for people that, whether you have tremor or not, most people have tremor, but not everyone. So for the people that do have tremor, they'll tell you that my tremor becomes worse when I'm anxious, and then the anxiety makes my tremor worse. So it just becomes this vicious cycle that things like anxiety can definitely worsen people's physical Parkinson's symptoms. And so, as far as mindfulness and stress reducing techniques, they do work in reducing people's stress and depression in Parkinson's disease, and therefore kind of positively feeding back on the physical symptoms. People do report that they have even physical improvement if their stress levels are lower. And this is something that we know, but it was looked at as recently as 2021. As far as depression goes, the numbers are about 40 to 50%. Some patients have depression that was going on long before their official clinical diagnosis. And then for some people, they'll say, nope, I was never depressed, but the diagnosis, receiving that diagnosis of Parkinson's, which is life-changing, can cause, in some people, a kind of a reactive depression where, it's a label that's going to be with you for life, and it changes the way that people look at things. So having that, when the diagnosis is initially made, for some people, it can be very, very hard to swallow as a diagnosis. And a lot of times there can be some depression when it's first made. And then similar to anxiety, like we talked about, for some people, depression or feeling an overwhelming sadness can be a non-motor manifestation of off time. Again, similar to anxiety, it kind of fluctuates throughout the day with a dopaminergic medication. So similar to anxiety, the treatments are, making sure that we're optimizing the dopamine to make sure we're not, leaving our patients with too much off time during the day if we can help it, if that's the underlying cause. Otherwise, SSRIs are the mainstay of depression treatment in Parkinson's disease pharmacologically, although a lot of people will opt to do things like, will choose to, exercise or be more social, things like that. COVID hasn't made that easy, but nonetheless, there are people that choose more non-pharmacologic strategies like the mindfulness that we talked about. Apathy is something that's pretty common and sometimes confused with depression. So apathy, as a rule, we tend to think that it's something that maybe in the beginning might be dopamine responsive. So the big difference, and there can be a lot of similarities, but the big difference between apathy and depression is that the patient, usually if they're sitting in front of me, when I ask them, usually it's frankly, it's family members that bring it up and they say, he or she's maybe losing interest or seems bored, doesn't want to do the same things that they want to do anymore. If I ask the patient, are you feeling sad? Are you feeling pessimistic? Are you feeling, suicidal? Do you feel badly? They say no. They say, no, I feel fine. And they're kind of nonchalant and say, I'm fine, everything's fine. And they seem to minimize the symptoms because they personally aren't very bothered by them, versus the depressed patient has feelings of sadness and helplessness, hopelessness, and they feel, and they'll tell you that, yes, I am depressed. Yes, I am sad. Yes, I am upset. So apathy in some ways can be frustrating for the family and caregivers, because in a lot of ways, Parkinson's, is a full-time job. And as you guys know, you have to be very, very motivated and, do your exercises and, things like that, keep your body moving, keep your mind moving. And if someone has apathy, it's very hard to motivate that person to do anything. And so family oftentimes will complain that, well, he's not going to help himself. How am I supposed to help motivate them? So it's a big issue. As you can see by the prevalence number, it's all over the map. So as low as 15%, depending, or as high as 70% of patients, depending on what you read. But again, primarily it's this loss of motivation, this lack of interest without the accompanying sadness that we see in depression. And like we mentioned, can be very troublesome for family and our caregivers. We typically try our luck with dopaminergic medications, and sometimes we're lucky where, treating the Parkinson's disease with dopamine helps the apathetic symptoms as well. There is a compound called IRL 752. It's being looked at for also dementia. And so this is being studied in phase 2 trials right now, but there might be some thought that this compound may potentially help apathy in the future. So that's being looked at. As far as impulse control disorders, if you've ever been prescribed a dopamine agonist, you've probably had us ask you in the office if you're gambling, or if you're excessively shopping, or if you're hypersexual, or if you're overeating. So these impulse control disorders are thought to be a side effect sometimes of too much dopamine, specifically dopamine agonists. So they have been reported without these medications, but very, very commonly seen in dopamine agonist use. So the solution with this situation is actually to reduce medication, where increase dopaminergic medication. Punding, if you've ever heard of this is sometimes patients will have kind of repetitive, purposeless behavior. So sometimes they just, will organize their closet and unorganize their closet and keep kind of doing the same task over and over, undoing it and redoing it, kind of become obsessive with it, but it doesn't really serve a purpose. And so this is referred to as punding and kind of falls under the umbrella term of impulse control disorders. And then there's dopamine dysregulation syndrome, where we have patients that say we prescribe X amount of Sinemet, they'll go through that, say month supply in a week, or that 90-day supply is gone in 30 days. And they'll tell you usually that they're self-medicating and taking a lot more medication than prescribed. We typically, as a rule, don't have a huge problem with our patients experimenting with medications, especially because sometimes there can be a big wait between appointments, and the medication admittedly is very, very short acting. But these patients are taking way too much medication and then becoming also impulsive. And typically this is something that is reported to us by family members, though it's our job to ask about this. Also a red flag is if, patients are calling the office asking for, refills on medications, or wouldn't, be due for a refill in a while. And again, treatment strategies overall, there's, social activities and trying to be social and mentally active. There's physical activity like aerobic exercise. We have good data to support specifically aerobic exercise, not only for the motor physical symptoms of Parkinson's, but also some of these neuropsychiatric symptoms like anxiety, depression, pain, and also cognition. And then again, because we're dealing with Parkinson's disease, we always want to make sure that we've optimized the dopaminergic therapy to give our patients the best fighting chance at some of these other non-motor symptoms. And when all else fails for things like anxiety and depression, we work with our psychiatrists, but for the most part, we end up starting some low dose serotonin reuptake inhibitor, an SSRI. And again, because like with that first slide that I mentioned, we don't have great evidence. There's, not to say you can't use SNRIs or tricyclic antidepressants, but SSRIs are thought to be maybe the lowest risk, meaning less potential side effects. These medications all have the potential to worsen tremor, so it's something to kind of keep in mind. But nonetheless, we rely on them when we need to. As far as cognitive impairment, this is a big topic and people always have questions about this, especially when they're first diagnosed. And this is a broad spectrum of symptoms. And so cognitive impairment can be as subtle as something called bradykhrenia. This is when the patient, is sitting in front of us and maybe we ask a question and it takes a little bit longer to process and maybe they're slower to respond. So it's not to say that there's any true cognitive impairment, but things are just kind of slower. And so that's this kind of concept of bradykhrenia. Sometimes people will write that in their notes and say the patient is bradykhrenic. And all that's referring to is that maybe if we ask a question, there's a little bit of digestion time that kind of takes place. And then, when you answer the question, it's completely appropriate. There's no issue with understanding or comprehension. It's just a little bit of a slower time to answer. Then there's mild cognitive impairment, where people might have some objectively, maybe say a lower score, less than normal on something like a Montreal cognitive piece of paper test that we do in the office, or you draw a clock or name some animals, try to remember 5 words, do some math, things like that. And if the score is below what's considered the threshold for normal, then it kind of gets labeled as a mild cognitive impairment, though people are usually completely independent with their activities. And then there's Parkinson's disease dementia, which is diagnosed when there's at least one domain that's severely affected, and people have issues with daily activities of daily living are affected, and typically patients aren't driving, things like that. The domains that may be affected are kind of all over the place. So it's pretty heterogeneous. So there's not just one profile that fits, but for the most part, classically, when we do formal neuropsychological testing, which is when a PhD will sit there and test your memory for like 4 or 6 hours. So it ends up being kind of like a full day event. Most people with Parkinson's will have a little bit of dysfunction with executive function. So this is difficulty maybe planning out your day, switching tasks, or processing information. But also attention, working memory can also be affected. And some of these papers that are listed here are actually looking at the idea of, okay, how common is cognitive impairment actually in newly diagnosed or early mild Parkinson's disease? And what we originally, typically we think of something like cognitive impairment as something that maybe is more, something that happens later, but oftentimes the range, it varies, but between 20 to 40% of people that are diagnosed with Parkinson's disease probably meet criteria at that time of initial diagnosis for mild cognitive impairment. So it's not as late of a finding as we'd like to tell ourselves or like to think, unfortunately. I mean, this probably also has to do with Parkinson's kind of preferentially picking on patients older than 60. And so there's some of that too, but overall it wouldn't be uncommon, I would say, to have some cognitive impairment even initially on initial diagnosis. As far as medications for cognitive impairment, like we said, rivastigmine, which is all the way at the bottom of the screen, does have FDA approval for Parkinson's disease dementia. But as far as mild cognitive impairment, we really don't have any data to say, use one medication versus the other or use any of them, because for the mild cognitive impairment, there really isn't any data. And if you look in the middle, towards the middle of the table, that IRL 752 compound that I talked about potentially being looked at for apathy is also being looked at for maybe cognitive decline in Parkinson's disease. So again, it was looked at 32 patients over 4 weeks, but there seemed to be some improvement in executive function. And again, this is something that's being looked at more for safety right now, though later on it probably will have bigger studies to come. As far as Parkinson's disease psychosis, this is something that, again, depending on what you read, the numbers vary, but it's thought to affect about 50% of people with Parkinson's, especially if they've been on dopaminergic therapy chronically, which is most of our patients. Some risk factors include older age, more advanced disease, cognitive impairment, and then depending on what medications you're prescribed, certain medications are more likely to cause hallucinations than others. For as far as coping strategies, because you'd be surprised at how many people will say, yeah, okay, so I have some hallucinations, but they don't bother me, or they're pleasant. A lot of people will report, seeing things like bunnies or cats or small children, but they're pleasant, they keep them company, they're not bothersome or scary, they don't feel threatened, and the insight is there, meaning my patient can tell me, yes, I know it's not real, it's not hurting anything. So oftentimes people have a sense of humor about it. There's some people that will paint or draw the things that they hallucinate. So there actually is some research behind art therapy and hallucinations. Sometimes just reassurance from family members that what they're seeing isn't there. Night lights have been helpful. So there are some people that tell me that they plug in night lights and leave them on at night all night. And then there's some people that have gone on Amazon and gotten like those they're battery operated, but they're motion sensitive or motion censored night lights. And so they only kind of go on if you're waking up at night or moving, theoretically, kind of letting us know that you're awake. And so some people like to put those, especially, throughout the hallway, maybe on the way to the bathroom, around stairs, things like that, because oftentimes hallucinations are more likely in the when it's dark, or the evening hours when the lights are dim, low, things like that. So lights can be helpful. And for people that have, so say someone calls our office and family says, they're hallucinating. The first thing we do, no matter what, is make sure we're not missing any kind of underlying infection or something else going on metabolically. So we oftentimes either ourselves will order some blood work and a urinalysis, or refer patients to their PCP to make sure nothing like that is going on. If we've looked for underlying medical issues and there's none present and hallucinations are still there, we're looking at the medications that we're giving you. So if we have you on an anticholinergic like trihexyphenidyl or Artane for, say, tremor, or some dopamine agonists, those can be culprits. So anything that increases dopamine can increase your risk of hallucinations. And for Parkinson's disease, what do we do to all of our patients? We give them a bunch of dopamine. So the medications that we give our patients to make them feel better physically then run the risk of causing hallucinations. And so it's a pretty delicate balance of, how much do we give to help the physical symptoms? But if we run into side effects like hallucinations, we may have to either throw a medication on top, something like Seroquel or Clozaril, pimavanserin or Nuplazid that's FDA approved, or even the cholinesterase inhibitors. There's anecdotal evidence for things like Aricept or rivastigmine, Exelon, which is FDA approved, again, for Parkinson's disease dementia. Sometimes these medications that are for dementia can help hallucinations. But oftentimes, if we can get away with it, we can simplify the medication regimen and get rid of some of the medications that maybe aren't doing a whole heck of a lot anymore for physical symptoms and are possibly contributing to the hallucinations. So sometimes it's a tug of war between physical symptoms and hallucinations. And we, luckily we don't get into situations where we have to pick and choose too much, but sometimes we have to, to get the hallucinations under control, especially if they're pretty severe and there's no insight, meaning you don't know that they're not real and you're scared, you're threatened. If you see children outside, you're running outside because you think they're going to get hit by a car. Sometimes they can be pretty scary. And in those cases, depending on what we're trying, we may have to actually reduce the medications we give you for Parkinson's disease, and maybe make it so that your physical symptoms are a little bit worse to at least get the hallucinations under control. And that, the medications are always reassessed. So it's not a permanent thing necessarily, but we've been stuck in situations where sometimes we do have to peel back on some of the Parkinson's medications to get rid of the hallucination. So this one can be tricky. And again, it's not that every single person with Parkinson's disease will hallucinate inevitably, but they're not uncommon either. So again, it's our job to ask about this when we see you and when we talk to you, because they're oftentimes minimized or not reported. People are scared of being thought of as, crazy. And so a lot of times people will not kind of people don't offer or don't like to offer this up. So oftentimes it's family members that are concerned, or if we specifically ask you. But in my experience, if we don't specifically ask, oftentimes, people don't love talking about this one. As far as disorders of sleep, there are many. And so I like this because stage 1, the lightest stage of sleep, or drowsiness, 1 to 7 minutes. I mean, I don't know any of us who get to sleep that soon after we lay down, but nonetheless, our patients with Parkinson's disease have a lot of issues with sleep, anything from difficulty getting to sleep or staying asleep. So the sleep fragmentation, REM sleep behavior disorder is a big one, excessive daytime sleepiness, and then just this overall fatigue, which technically isn't a sleep disorder, but everything else that disrupts your nighttime sleep can certainly lead to fatigue during the day. And so as far as disorders of sleep go, with under the insomnia umbrella, and this is thought to be with sleep initiation and sleep maintenance, this typically is more prominent at the earlier stages of sleep versus during the REM sleep. We see vivid dreams. Like vivid dreams can happen at any stage of sleep, but are more common at during REM sleep. And so if someone either wakes up during REM sleep or right after a REM sleep cycle, they're more likely to remember their dreams. So when people are able to tell you, hey, I had a vivid dream, it's usually because of that. And then REM sleep behavior disorder, we'll kind of go into a little bit deeper because it's pretty common in Parkinson's, but obstructive sleep apnea. This is a big one that also can happen at any time of sleep, theoretically any stage, but in REM sleep, because there's muscle tone relaxation, those the muscles of the mouth, the throat are more relaxed, and people are more likely to have sleep apnea during the REM sleep, or this deep level of sleep. And sometimes people will report difficulty with sleep, and we as neurologists are referring patients to sleep medicine for sleep studies and things like that to make sure we're ruling out any other issues that might have a treatment such as CPAP or BiPAP, because a lot of OSA for the most part seems to be most problematic during REM sleep, and our Parkinson's patients already have issues with REM sleep to begin with, so we don't want to confound things by leaving untreated sleep apnea kind of on the table. It's a low-hanging fruit in a lot of ways, and so we always want to make sure we're treating apnea, whether obstructive or central, frankly. If we don't want to miss the diagnosis and miss the opportunity to treat it, because it can make a big difference. As far as insomnia goes, there's impaired sleep initiation. This can be due to anxiety or people not being able to turn their minds off. Sometimes people have restless leg type symptoms, wearing off symptoms of their Sinemet. So sometimes people will say, I can't get to sleep because my tremor won't let me get to sleep, or my legs are cramping up or curling up on me, or I'm having trouble getting comfortable in bed, things like that. Versus impaired sleep maintenance, this is when you've gotten to sleep, but then you can't stay asleep. And sometimes this has to do because with nocturia, you're having to wake up several times a night to get to the restroom, or the medications are wearing off. So physical Parkinson's symptoms can impair sleep maintenance. And then things like obstructive sleep apnea or REM sleep behavior disorders can also wake up patients out of sleep, unfortunately, and disrupt sleep, or not let people get to the kind of the deep restorative sleep as well as they could be. And so with vivid dreams, for example, so we're starting with vivid dreams. They technically can occur again throughout any stage of sleep, but if you're remembering them, they're most likely occurring during REM sleep. And this sometimes can be a side effect of medications, especially some of the memory pills out there. There's some studies that suggest that the cholinesterase medications, if given at bedtime, can maybe contribute to vivid dreams. And so sometimes we just dose the medication at a different time of day, like the morning, and that seems to go away. There's reports of vivid dreams occurring with amantadine as well. But oftentimes we tell our patients that, the vivid dreams are a part of Parkinson's disease. And as all of you know about REM sleep behavior disorder, this is now when people have vivid dreams, but they're also acting out their dreams. So they might be punching, yelling, shouting in their sleep, punching the bed partner, falling out of bed, things like that. So I've had a lot of patients sustain injuries because of REM sleep behavior disorder. So that's a big one. And when people have REM sleep behavior disorders, they diagnosed on a sleep study that was being done for apnea. And, without a diagnosis of Parkinson's, they don't have Parkinson's, but we know that people that get diagnosed with REM sleep behavior disorder, 80 to 90% of them, like a huge chunk of them, will go on to then later on develop a neurodegenerative condition, whether it's dementia, but about 50% of those people will end up probably with a Parkinsonian type of type of picture. So REM sleep behavior disorder can be kind of a big clue or maybe a kind of a marker or say a red flag for maybe Parkinson's disease later in life. Obstructive sleep apnea. So another one that's kind of categorized under REM sleep behavior disorder, though again, it can occur at any stage of sleep. Because it can be associated with daytime sleepiness, with memory issues. So when people are pausing and they stop breathing multiple times a night, they're actually robbing their brain of oxygenated blood. And so cognitive impairment can be seen because you're not perfusing your brain with rich oxygenated blood with nutrients. And so a lot of times when patients tell us that they have maybe memory issues and fatigue, don't sleep well, again, it's low-hanging fruit as far as I'm concerned to make sure that we're not missing an apnea that can be treated with intervention like something like CPAP. And we have data to say that CPAP improves how people tell us that they sleep. So when we say subjective, that means patient-reported sleep quality, cognition, and as well as anxiety. So lots of reasons to make sure that we're checking for apnea so that we don't miss the opportunity to treat it. As far as REM sleep behavior disorder, it's been described, it was described in the 80s. And what this looks like during, say, a sleep study is during the REM sleep, when people are hooked up to the EEG or the brainwave test portion of the sleep study, they're in REM sleep because their brainwaves show that activity. And in the EMG, which is put in some of the muscles in the limb during REM sleep, so the EEG is showing REM sleep and the EMG is actually showing that there's loss of this atonia. So during REM sleep or rapid eye movement, the skeletal muscles are technically supposed to have a lack of tone or kind of be paralyzed, so to speak. And the only muscles that are moving are your eye muscles and your diaphragm, so you're breathing. And so when people have these muscle contractions and movements during this REM sleep, it's considered REM sleep behavior disorder. And again, like we talked about earlier, may precede something like Parkinsonism or dementia, and very strongly associated with alpha-synucleinopathies. Alpha-synucleinopathies being Parkinson's disease, multiple systems atrophy, and dementia with Lewy bodies. So for people with REM sleep behavior disorder, there's about a 6% chance per year that they're going to maybe convert to something neurodegenerative. And after 12 years, there's about a 73% conversion rate. So again, people that didn't have an official diagnosis, but got diagnosed with REM sleep behavior disorder on a sleep study, later on, it's a strong precursor, thought to be a strong precursor for neurodegenerative conditions. And so with REM sleep behavior disorder, treatment options, we make sure the environment is safe. So sometimes people end up having to put things like bed rails or just kind of cushions around the bed, depending on where the bed is in the room, is it by a wall, things like that. And then just counseling, meaning we talk about it. So as long as everyone in the family knows what this is and what to kind of look for, sometimes we just keep an eye on it because it may be occurring very infrequently. Again, we have a short or a low threshold to send people to sleep medicine just to make sure we're not missing any other kind of sleep disturbances that may need different treatment. But melatonin, for people this is occurring pretty frequently, several times a week, and we're running into injuries or near injuries, or where if there is a bed partner or someone sleeping in the same room, that person's sleep isn't disturbed. And so if someone has a bed partner, even if you personally aren't bothered by your punching, shouting, yelling, thrashing in bed, but your spouse is bothered, we will treat you with medication just to make sure that that other person is not getting disturbed. And so melatonin and Klonopin are the two biggest things we use, though sometimes there is evidence for things like some of the memory medications. There's even some reports of carbamazepine, which is a seizure medication, though I probably would not use that one. And then bed alarm systems. I don't have many patients that have bed alarm systems, but this is similar to like hospital bed alarm systems, that when there's movement or someone's trying to get up or maybe fall, that an alarm goes off so that it alerts the family that something might be going on. I've had people put in things like cameras and just have, so if they're not sleeping in the same room or even sometimes in the same household, I've had family members set up, obviously with the patient's permission, but set up kind of like baby monitors almost, just to make sure that everything is is safe. And if any time that they want to, they can look on their phone, let's say, or tablet, and have some assurance that family members is safe in bed. For daytime symptoms, so fatigue is just a big complaint, I think, for all of us in general. So about 5 to 10% of all primary care appointments are for the chief complaint of fatigue. So it's very, very common in general. But with Parkinson's disease, we think it affects about 33 to 70% of patients. So again, when the numbers are all over the place like that, we're not really sure, but I feel like we hear about it pretty frequently. So I think it probably affects most people with Parkinson's disease. Can be associated with depression or apathy, but fatigue is something that I think most people would report if asked about. Excessive daytime sleepiness, 50 to 70% of Parkinson's disease, and these sometimes are used interchangeably, though excessive daytime sleepiness would infer that you're sleeping during the day and maybe falling asleep abruptly, like sleep attacks, which can be seen with dopamine agonist use, or just taking naps frequently during the day, maybe like say an hour after you take your medication. Sometimes dopamine can be sedating in some people. And so for some people, they take their Sinemet, and when it's peaking, like some person might get dyskinesia, some person might just get really kind of very, very sleepy or tired from the medication. And then if you're sleeping during the day, you're not going to sleep well at night. And so again, becomes a bit of a vicious cycle. For risk factors, males seem to be more affected by excessive daytime sleepiness. People that have had Parkinson's for longer have maybe more severe symptoms, and then that use of dopamine agonists. So that's a pretty common side effect from dopamine agonists. There's actually a warning on medications like Requip or Mirapex in the package insert that, we've had patients completely, fall asleep at a red light behind the wheel or things like that. So it can be something to at least know about. Hopefully it never happens to you, but definitely something to be aware of, that it's a potential side effect. And then as far as prescription medications, there's things like Provigil or Strattera. Sometimes insurance companies like to deny these medications, but if we need to use something to perk our patients up during the day because they need to function at work or something like that, then we use them. But again, can be difficult to get covered by insurance sometimes. And then caffeine, good old caffeine. I'm barely a human before I have 2 cups of coffee. And so a lot of people will report that, yeah, no, caffeine definitely helps their daytime sleepiness. So I think most of us would vouch for caffeine's effect on that. This is something called Sinosi. It's already on the market for narcolepsy and obstructive sleep apnea, but it's being looked at for maybe daytime sleepiness and Parkinson's. So again, phase 2 trial, small trial, but this compound, which already is on the market and kind of works on increasing or blocking the reuptake of dopamine and norepinephrine, so that you have more dopaminergic and norepinephrine around. This is thought to maybe help with daytime sleepiness and Parkinson's, but again, more studies probably need to be done before we would off-label prescribe something like this. Probably wouldn't get covered by insurance at this point. So overall, the treatment approach, as annoying as good sleep hygiene seems to be, that ends up being the big one, is making sure that, and we all know this because we recommend the same thing for ourselves that we recommend to our patients, but avoiding electronics 1 hour before the desired bedtime, avoiding TV or using the phone or just iPad screens in bed. They say to only have your bed and your bedroom kind of be associated with sleep or intimacy. So for people that are having trouble getting to sleep, it's actually recommended that you kind of get up and go to a different room so that your bedroom and your bed isn't associated mentally with struggling to get to sleep and being wide awake and staring at the ceiling. So if, the recommendation is actually that if you're having trouble getting to sleep, maybe trying to go do something else in a different room for a little bit and then try sleeping again. And as this stuff is all easier said than done. And I will admit that I'm probably have the worst sleep hygiene, but that's what the recommendations are. Reducing or discontinuing sedating medication. So this sounds counterintuitive, but if we're being prescribed something that's sedating during the day, then of course you might sleep more during the day. It throws off your sleep cycle. And so this can be a big challenge to kind of get this stuff straightened out. But a lot of times the medications that you're being prescribed during the day might be causing some sedation, and anytime we can get reduce the dose or even potentially get away without it, we do that to try to get people on a good kind of sleep wake cycle. A lot of patients tell me that, hey, I'm retired, so I can kind of do whatever I want, and if I want to stay up really late and watch TV and sleep in, then, a lot of people do tell me that they have kind of adjusted hours and they're not on the 9 to 5, working man schedule. But nonetheless, as long as people are getting enough sleep, then I don't make a huge fuss about stuff like that. Melatonin, again, 5 to 10 milligrams at bedtime can help people sleep. For REM sleep behavior disorder, sometimes we go even up to 20 milligrams. Beyond that, doesn't seem to do a whole lot more. Sleep aids, we don't love using these because they can be habit forming, but sometimes we do need to use something like, an Ambien or something like that. And if the sleep issues are related to physical symptoms of Parkinson's disease, then sometimes we do prescribe actually, Sinemet to give to people at bedtime, or carbidopa, levodopa at bedtime to help kind of hopefully carry through and linger throughout the night, so that some of these motor symptoms aren't getting in the way of falling asleep or then waking you up from physical discomfort. So that can be a strategy too, depending on what's reported. Daytime symptoms of fatigue, again, exercise, engaging in activities, caffeine, and as a last resort, stimulant medications. And I say that not necessarily because we don't want to prescribe them, but it's another pill with with potential side effects, and also oftentimes insurance, again, can be challenging with some of those. As far as autonomic symptoms, I know I'm running a little low, so I should probably try to fly through these, but autonomic symptoms can be seen in Parkinson's disease, and they affect quality of life. The prevalence rate, again, is huge all over the place, so hard to really know, but I would say most patients have at least some symptoms. Orthostatic hypotension is a big one. And so this is when people have blood pressure fluctuations when going from sitting to standing, or from when lying down to sitting to standing quickly, things like that. And so by definition, if someone's systolic blood pressure drops by 20 millimeters of mercury, or the diastolic blood pressure drops by 10 millimeters of mercury, and the big thing is, and it's symptomatic, meaning that someone's blood pressure can drop, and we make note of it and we check it sitting and standing in the office, but we're not going to make a huge fuss about it unless you tell us, hey, I'm lightheaded. Yes, I felt dizzy when I went from sitting to standing, or I feel like I'm going to pass out, or some people refer to it as coat hanger pain, but some people, instead of telling us they're lightheaded, they'll say, oh yeah, when I stand up quickly, I sometimes feel this like shoulder neck pain, because those muscles actually aren't getting perfused. The blood pools in the legs, and you stand up quickly, doesn't have enough time to kind of go up north and perfuse the brain, and people kind of feel like they might pass out. And so conservatively, we manage this with, we harp on increasing fluids and actually increasing salt. So the cardiologists typically don't love us, but we're always telling people to take more salt in, especially in the morning. Permissive hypertension, meaning as people get older in general, sometimes low blood pressure is more dangerous than high blood pressure, because it can lead to thigh falls. Thigh-high stockings, I don't have any patient who will put on thigh-high stockings and actually keep them on. Very difficult to get on, difficult to get off, and overall just uncomfortable. But the abdominal binder idea seems to work pretty well. As silly as this sounds, people will use things like Spanx or something like that, where that kind of binds the abdomen, and a lot of the blood that's kind of stuck in the belly being used for, say, digestion or things like that will kind of migrate north with an abdominal binder. Is it comfortable? No, but I think it's probably a lot more doable than thigh-high stockings. Head of the bed of being 30 degrees when sleeping. So this is not just like the head or neck, but it's actually your entire trunk being at 30 degrees can help with orthostatic hypotension. And the small frequent meals, the reason why we bring this up is because if you're digesting a huge meal, and it's a large meal, all the blood is kind of rushing to the gut, and then you stand up from the dinner table and you feel lightheaded. So smaller frequent meals make it so that that blood flow isn't all in the same area at once. And so these are some of the blood pressure goals. But again, we only fuss about this if you're actually symptomatic. And we always look at the medication list, because sometimes it can be our medications that can be contributing, but also sometimes the PCPs will have patients on various antihypertensives or diuretics, things like Lasix, for unclear reasons. And so those medications need to go first. And if we need to, we can add medications to raise your blood pressure. So I'm going to fly through this. So constipation, there's some thoughts that Parkinson's may actually start in the gut and then through the vagus nerve kind of travel to the brain. So this is called the gut origin hypothesis. There's people that believe in this and people that aren't sure, but nonetheless, we know that that constipation is very, very common in Parkinson's and probably predates the official diagnosis of the physical disease by, sometimes 10 years. So very, very common. And can be a cause actually of delayed medication on time or dose failure. So if someone's very backed up and constipated, then the medications aren't traveling well to the gut and then to the brain where they need to go. Over-the-counter tips for constipation, you guys are probably very, very familiar with a lot of this. Miralax, I would say most people probably end up taking Miralax on a daily basis. And the goal is 1 bowel movement a day, or at least every other day if we can't get 1 good bowel movement a day. And when we say 1 bowel movement, say every other day, we want to make sure that you're not having to be too uncomfortable or straining too hard for this. So most people really up their hydration and up the fiber, and are taking things like stool softeners as well. Stimulant laxatives, so something like Dulcolax, is it the end of the world if we need to take it? No, but in some people can be a bit habit forming. And so the goal ideally is to do this other stuff as much as possible so that you're not relying on a stimulant laxative, though I do have people that frankly require it. And this would be to avoid things like, ER trips to get manually disimpacted, or small bowel obstructions, or even surgeries. So this stuff can happen. So constipation is a pretty big deal in Parkinson's disease. So we want to be more proactive to avoid it than reactive, where we look back and say, oh man, we haven't had a bowel movement all week. What do we do? Genital urinary dysfunction. So this includes sexual dysfunction and urinary symptoms. It's very, very common, affects 60% of patients. I would say probably even more than that, especially the males, though, it's hard to sometimes know, okay, what's related to the prostate, what's Parkinson's disease. But this is one of those things that we typically defer to our urology colleagues for help with, with the exact diagnosis, make sure there's nothing structural, and then kind of figuring out the mechanism so that the medication that's prescribed does you favors and not causes just side effects but doesn't even work. So for the GU thing, most of us will refer out to urology. And so bladder dysfunction, again, pretty common, and there's medication, sometimes Botox, depending on the mechanism. Catheterizations, like self-catheterizations, may even be required. Ideally, we don't have to resort to those measures, but it's something that's out there if there's urinary retention. As far as sexual dysfunction, this one, I think it's probably under-recognized. We don't talk about it. It doesn't get a whole lot of attention. So there's a few studies looking at Viagra. Overall, it didn't seem to improve quality of life a whole lot. So even if there was improvement in, the erectile dysfunction symptoms, as far as overall quality of life and sexual dysfunction didn't seem to be significantly improved. And so this is something that, I think most people don't ask enough about, or it's not brought up often, though if we asked about it more, we would probably find that most people do report some level of sexual dysfunction. And then some of the antidepressants that people are prescribed for anxiety and depression can cause sexual dysfunction as a side effect. So this one's a tough one. And whether it's more of a physical issue or even a more psychological issue, this is probably a challenge and an under-discussed, under-recognized area of Parkinson's disease. Abnormal sweating. So we run into this. It's thought to be related to dysregulation of the autonomic nervous system. And so this can be related to medications wearing off or dyskinesias. And sometimes it's not even medication related. And if people have too much sweating, things like propranolol, ditropan, even Botox can be used. But for most people, it's not super clinically significant. So I don't think I run into this as much, though it is definitely reported. And then when we talk about abnormal sweating, there's treatment for too much sweating. Most people don't complain a lot about too little sweating, so to speak, but there are people that just report they don't sweat as much. And same with skin. Some people report that their skin is oily. Some people report that their skin is dry. But nonetheless, it's all thought to be related to autonomic dysfunction. And then some miscellaneous things quickly. So again, Parkinson's disease, when we talk about dopamine, and then we're talking about the substantia nigra at the very tip of the iceberg, there's, below it is all the other parts of the central nervous system that are affected. And so anosmia, or the loss of sense of smell, before it was a COVID thing, it was, it's been a Parkinson's thing for much, much longer. And so the lack of sense of smell is pretty common. About 90% of Parkinson's patients, this lack of sense of smell makes it so that some people also don't have a great sense of taste. And so sometimes people will have a disinterest in eating. So we tell them, really try to spice up your food and make it so that you can taste the food better, so that maybe you enjoy eating more. But this is thought to contribute to weight loss. Weight loss, as a side note, is a very common complaint. We don't fully understand why people with Parkinson's seem to have unintended weight loss. But we do hear about it commonly. And what we offer is increasing calories and trying to just get more in, or at least more calorie dense foods if possible. And we try to refer to things to people like dietitians, so we don't have great access to dietitians sometimes. There's antidepressants that can cause increased appetite or weight gain as a side effect. So sometimes we resort to medications that as a side effect cause weight gain to help kind of boost appetite, but this is a tough one. And as far as dysphagia and speech changes, it's pretty commonly reported. And so it's thought to be due to incoordination of the oropharyngeal muscles, usually kind of up here. When people get formal swallow evaluations, a speech therapist will sometimes make recommendations on dietary modification if that's necessary. Because there's speech therapy that's actually, for swallowing versus speech therapy like the LSVT loud, that's more for the voice. But this is commonly reported. And if it's, if there's choking or anything like that, then we do a formal swallow evaluation and make sure that we if we need, that we know if there needs to be dietary changes made, so we don't run into aspiration. As far as, again, we kind of touched on this earlier, but early satiety and weight loss, again, we're not really sure. So the lack of sense of smell, the lack of taste, maybe some swallowing issues, gastroparesis, this concept of just slowing transit in Parkinson's, might make it so that whatever you eat maybe sits in your stomach longer, which we know this is the case. And so patients will maybe try to eat something and then it sits in the stomach, it's not really moving down, and so they feel full, the stomach is distended, so people eat less, and it takes longer for that food to transition and kind of transit through the GI tract. Or maybe, there's theories that people with Parkinson's kind of burn more calories just, for cellular function. And so maybe the demands for a Parkinson's patient, if say a person without Parkinson's needs 1,200 to say 2,000 calories to sustain bodily functions, maybe the Parkinson's patient has higher targets or higher caloric needs. So there's lots of different theories. Frankly, we don't really have a great answer. And a lot of times I've seen neurologists just say, go talk to your PCP and, make sure everything else looks okay, your thyroid's okay, things like that. So we don't have a great answer for this one. Anytime our patients are over 50, especially if someone's having unintentional weight loss, we want to make sure just all the cancer screenings are up to date so we don't miss something else. Sometimes I have tunnel vision and I can make everything be Parkinson's related. So we just always have to remember that people can have other things kind of pop up or go wrong, so to speak. And it's not just that everything that happens to you is completely related to Parkinson's disease. So again, as someone who sees Parkinson's every day, Parkinson's can cause a lot of symptoms. And so GI symptoms like nausea and vomiting oftentimes can be related to medications. So carbidopa, levodopa sometimes needs a little extra carbidopa with each dose. Sometimes we tell people to eat, we frankly tell patients to take the medication with food, or at least a light snack, so that there's something in the belly with each dose to maybe avoid some of the nausea. We definitely don't want our patients going to the GI doctors and getting prescribed things like Reglan or other medications that block dopamine receptors, because that will kind of undo what we're trying to do with your Parkinson's medications. So the ones that are safe are Zofran, Tigan, and domperidone isn't available in the US, though some people will, get a paper prescription from us and then make it their way to Canada or order it online through Canadian pharmacies and obtain it that way. But that one is also safe to take in Parkinson's disease for patients who need something for nausea and vomiting. Again, sexual dysfunction, I know we kind of hit on it earlier. I think this slide is out of place. Sorry about that. Sialorrhea or drooling. So this is a fancy way of saying excessive drooling. So people with Parkinson's, it's not like you're producing too much saliva, you're just not swallowing as frequently. And so the saliva kind of pools in your mouth and kind of, gravity does its thing. And so all of us drool a little bit in our sleep. So in our sleep, I would say it's not uncommon, but if you're finding that you're drooling, during the day, or staining your mask or staining your clothes, or if you find the need to walk around with a little cloth, then we, might need to do something about the drooling. And so we usually, atropine eye drops, they taste really gross. And again, they're eye drops, but atropine eye drops on the tongue can sometimes help. Robenal isn't great because it can have a lot of systemic side effects. So actually botulinum toxin injection, so Botox or Myoblock or Xeomin are all approved for drooling in Parkinson's disease, and so or just excessive drooling in general. So these injections can be done where we kind of inject the parotid gland, which is this huge gland kind of in front of your ear, and then the submandibular gland, which is kind of under the jawline, so to speak, and it's actually pretty big too. The sublingual gland right here, I do not inject. So I don't actually know any movement disorder doctors who go after this one. Some people will only inject the parotid, especially if there's some dry mouth that's also reported, because believe it or not, someone can report dry mouth and drooling at the same time. So if someone has a significant drooling, I always make sure to do the submandibular gland as well. But if it's just mild and there's some dry mouth, maybe we might just start with the parotid and see how we do. But Botox injections can be very, very effective, though they do have to typically be repeated every 3 months. Sometimes I get lucky and it'll last someone 4 months or 6 months, but for the most part, the duration is about 12 weeks or so. Vision changes, again, common complaints are double vision or blurred vision, or more commonly, people will say I have difficulty reading or kind of focusing my eyes. And so it's typically diagnosed by ophthalmologists as convergence insufficiency, where the eye muscles don't kind of coordinate well when you're trying to focus your eyes. And so oftentimes our ophthalmology colleagues will offer things like prism lenses to help with that. But vision changes, it's not that they're uncommon, but these complaints are common, but probably not as common as some of the other things we've already hit on. And then malignant melanoma. So there's lots of kind of thoughts on this. There's some people that think there's an issue with the immune system, or maybe something to do with genetics, but dopamine and levodopa is an intermediate product for for the synthesis of dopamine and melanin. And so there is, kind of from kind of a biological standpoint, the origins of dopamine and melanin and melanocytes, these cells are kind of produced from the same origin. And so that's thought to be also contributing to why people with Parkinson's disease might be at a higher risk of melanoma or skin cancer than the general population. For a while, they used to think it was related to Sinemet, but that's kind of been disproven. So it's not thought to be that it's the carbidopa, levodopa that's raising the risk of having Parkinson's itself. And so overall, we just want to make sure that our patients, A, know about it, B, they go to a dermatologist or have a dermatologist to just make sure, you're looked over, once a year, and then, limit unprotected sun exposure. So just, wearing your SPF. Most of my patients, when they go to a dermatologist for, a suspicious lesion or a mole, it comes back as something like basal cell or something, not melanoma. I think I've had one patient who's had a lesion come back as melanoma. So, but nonetheless, something to be aware of. And that's it. So sorry I went over. Mary Sue, if there's any questions, I may have to
I know you've got another meeting, and I'm so grateful that you covered all this material.
Yeah, if you email me, I can try to hit some of the questions. I do apologize because I talked really fast, and 60 minutes for 60 slides is probably a bit much. So sorry, guys.
No, it was wonderful. Thank you. A few people are asking me if they would be able to get a copy of your presentation. Would that be possible?
Yeah, no, absolutely.
Okay.
Yeah, I can send that to you for sure.
Folks, the doctor will send me her presentation. If you want a copy of it, email me. You all have your email because that's how you got notified about this meeting tonight. So just email me and say you want a copy of Dr. Bulica's presentation. I'll send it on to you, okay? But I do know that Dr. Bulica has another meeting that needs to join tonight.
I apologize that I'm not Dr. Taylor. She's great. She helped train me. I texted her today, or actually she texted me. And so she's feeling better, but still not 100%. So
Yeah.
she did wish that she could be the one to talk to you guys tonight. And I know you guys signed up for Dr. Taylor, so I do apologize.
No, wonderful. We really appreciate you stepping in. So folks, with that, I'm going to say good night so that Dr. Bulica can get on.
Good night, everyone.
Good night. Thank you all.
Bye.